lecture.
Excellent, thank you. So really it's an honor and pleasure to be here. It's nice to see some familiar faces that I've known for many years. Before I start, actually, Mune, can you help me translate just how many of you are doing only pediatrics versus doing some adult and pediatrics?
どうですか?
Just so I understand who's in the
両
room.
方大人と子供と両方やっておられる方っていうのはthe four members the both they treat both adults
okay.
and pediatrics.
Okay, sounds good. So what I'm going to talk about today is lung and diaphragm protective ventilation. And I'm going to focus certainly on the pediatric aspects, but I think there's a lot of it that we're learning or have learned from adult concepts. So it's a mixture of both. So hopefully it hits kind of both audiences, and I think the concepts are applicable broadly in both adults and children. And then whether they go down to neonates is an important question that Carolyn will talk a little bit about too. All right, so I'm going to talk about lung and diaphragm protective ventilation. Here are my disclosures. Conceptually, right, what we've realized over the years is that there's a lot to this idea of protective ventilation. That really the ideal framework would be to thread the needle of preventing these three major causes of injury that we encounter: ventilator-induced lung injury, patient self-inflicted lung injury, and ventilator-induced diaphragm dysfunction. And sometimes these are competing risks, competing against one another. So really we have to try to find that way to balance those risks if we can. So what I'll start first with in the talk is really some conceptual review of this, but what I want to focus on is we recently completed a clinical trial testing a lung and diaphragm protective ventilation strategy. And so the framework here that I'm putting forward is sort of the concepts that drove some of the decision making that we had in designing our trial, okay, as they relate to these concepts of ventilator-induced lung injury, patient self-inflicted lung injury, and diaphragm dysfunction. So when we think about ventilator-induced lung injury, right, and the tenets of lung protective ventilation, three main concepts, right, that I think we're all aware of, but let's reframe them a little bit. The first is this idea of strain, the volutrauma concept, and so this is the idea that the tidal volume should be specific to the size of the lung, okay? Second concept is lung stress. More specifically, this is really the transpulmonary pressure, or the concept of limiting the inspiratory pressure, right, that we're applying so that we don't damage the lung. And then the last goal, of course, is the concept of atolect trauma, preventing recruitment, de-recruitment injury, either through recruitment and the appropriate application of PEEP. Now, all of these concepts, right, are crucial for all ventilated patients, but that does not mean that all ventilated patients are managed the same way, right? We don't use the same settings for each patient. There's individuality that we need to make for each patient to really capture these concepts. So let's start first with tidal volume, okay? So what's our evidence about tidal volume and ventilator-induced lung injury? Now, there have been several trials, right, in adult patients. I'm just putting up the ARDSNet ARMA trial as the first example of this here that certainly showed that a low tidal volume strategy on a population basis of 6 mLs per kilo was better than 12 mLs per kilo. But even in that first ARDSNet trial, this concept that a patient-specific tidal volume might be important came about, right? Because as you look at the benefit of the low tidal volume ventilation, 6 versus 12 mLs per kilo, it was clear in patients that had the most impaired respiratory system compliance, but those that had the more normal respiratory system compliance, it didn't seem to make a big difference of 6 versus 12 mLs per kilo, right? And now there have been a number of additional studies that have looked at this idea, certainly in adult patients, and it seems clear that this benefit of the low tidal volume ventilation is probably reserved most for those patients with the most impairment in respiratory system compliance, or the highest respiratory system elastance, right? Elastance being 1 over the compliance. Now, what about our pediatric data? We don't have RCTs, unfortunately, right? So we have observational data. And there's been an observational meta-analysis too, and I'm showing just the results of one of our studies that highlights that perhaps the relationship between tidal volume and outcome, either there's no clear relationship, or there's a suggestion that the patients that achieve the higher tidal volume, in fact, may be the ones that had the better outcome. But this may be because we use more pressure control ventilation, right? So we have a pressure control ventilation strategy, and if you embrace that idea of pressure control and you limit the inspiratory pressure that you're providing or limit the driving pressure that you're providing, then inherently the tidal volume that the patient achieves is going to differ based upon the compliance or the severity of the lung, right? So those patients that had the most severe lung injury, the highest lung injury score, are the ones that achieved the lowest tidal volume, and the ones that had the most preserved respiratory system compliance or the lowest amount of lung injury achieved the highest tidal volume. But this ties back to the important physiologic concept of lung strain. The strain on any structure is the change in size of that structure relative to its original size. So if we think about the lung, this is the tidal volume over the original size of the lung, where we're starting from, functional residual capacity. So if we go through the sort of simple illustrative example of a patient with normal lungs who's being ventilated with 10 mLs per kilo, functional residual capacity of 20, then the strain on that structure is 0.5. If that patient develops ARDS, we know about the baby lung concept. Functional residual lung, total lung size is reduced. Functional residual capacity is reduced, right? So if that's cut in half, but we keep the same tidal volume, the strain is doubled, right, on the lung. So what should we do? We concurrently decrease the tidal volume as well. As we think about adult recommendations, right, for tidal volume management, there's a range. Target is 6, range between 4 and 8, but keep the plateau pressure less than 30, right? What are our pediatric recommendations, right? Our pediatric recommendations from PALIC 1 was this concept that we should be using a tidal volume based upon compliance. That those with more preserved respiratory system compliance, right, we would use a tidal volume of 5 to 8 mLs per kilo, but those with the more compromised respiratory system compliance, we should be reducing the tidal volume further to 3 to 6 mLs per kilo. But we don't do that. That's not the norm in our clinical practice. It appears, at least, from the party study. So this was a study, right, that we did in about 145 international ICUs. And what we see is that our practice tends to be to use this roughly 7 mLs per kilo regardless of the pressures that we're putting into the system, or the delta pressure here, the peak inspiratory pressure minus the PEEP. So it doesn't seem like we fully embrace that concept of reducing the tidal volume based upon the compliance or the size of the lung. And at least with the observational data analysis, that seems to be associated with harm. Those are patients that are managed here, right, are 2 to 3-fold higher risk of mortality. Okay, so that's the tidal volume side. Let's talk about the pressure side. And I think conceptually, we've all learned from Marcelo's work, looking at that the relationship, of course, between driving pressure and mortality. And this underscores that idea of that tidal volume based upon the compliance of the lung, right? That if we take a driving pressure limit that we're not going to exceed, then inherently the tidal volume is going to fluctuate based upon the compliance, and those will have a lower tidal volume for those with the most severely impaired compliance. Now remember, the driving pressure, although we use it, is not the most precise measure of lung stress. If we want to think about lung stress, what we really should be focused on is the transpulmonary pressure. Either the transpulmonary pressure at end inspiration or potentially the transpulmonary driving pressure, because the driving pressure includes both lung and chest wall components, right? So if I raise the alveolar pressure to 30 centimeters of water, but that's because the pleural pressure is very elevated, that transpulmonary pressure stays low, alveolar pressure minus pleural pressure, right? But if my pleural pressure is low and I have that same alveolar pressure of 30, now I've got a very high transpulmonary pressure, and that risk of lung stress is highest. And this is why, you know, when a trumpet player plays a note, right, they don't blow a pneumothorax, because they keep a low transpulmonary pressure despite having an alveolar pressure that may be very, very high at like 150 centimeters of water. Okay. The transpulmonary pressure is also crucially important as we think about this risk of patient self-inflicted lung injury, right? Because remember, the transpulmonary pressure is what we need to inflate the lung. If I'm passive on a ventilator, right, then I give positive pressure to the ventilator, I raise my alveolar pressure, the pleural pressure maybe gets slightly more positive based upon the elastance of the lung to the elastance of the respiratory system. Spontaneous breathing, opposite, right? I lower the pleural pressure, right? Alveolar pressure drops maybe just below 0, and so that transpulmonary pressure is all coming from negative pleural pressure predominantly, right? But when I have a patient that's on a ventilator, right, in an assisted mode or in a supported mode, right, then that pressure is shared between the patient and the ventilator. And so here are the 3 examples of the same transpulmonary pressure, right? In this example, generated by positive pressure from controlled ventilation in a passive patient. Here, spontaneous patient with negative pleural pressure. And in this example, right, the mixed if we were to just look at what we see on at the airway pressure or the peak inspiratory pressure, for example, we will miss this whole component that the patient is doing, right, and underestimate what that transpulmonary pressure may actually be. So this is what underscores the idea of measuring this. And if the effort is very high that these patients are generating, herein lies the risk of the idea of patient self-inflicted lung injury. So how can we try to figure this out a little bit, right? And so if we go back to the equation of motion of the respiratory system, remember the pressure that is generated, that is needed, this inspiratory pressure, is shared between the ventilator and the patient when they're on a spontaneous or on an assisted mode of ventilation, and has two fundamental components: the elastic component, which is what the alveoli are seeing, and the resistive component, right, which is coming from flow and airway resistance. As we think about the risk of patient self-inflicted lung injury or ventilator-induced lung injury, then what the alveoli are seeing is what we care the most about conceptually as far as the risk of ventilator-induced lung injury or patient self-inflicted lung injury. So this is why we study this under static conditions, conditions of no flow. We do an inspiratory hold, for example. We make that resistive component go to zero so we can get an estimate really of what's happening at the alveolar level. And this is, of course, the plateau pressure, right, and herein the driving pressure. And I think it's important to remember, and I think this is not something we do routinely in pediatric practice, we should be measuring the plateau pressure on all of our patients, regardless of the mode of ventilation, regardless of whether they're active or whether they're passive, so that we can really understand what is happening at the alveolar level. And when we think about a passive patient, then what we should see, right, is what's here on the bottom left, where the plateau pressure is either the same or slightly lower than the peak inspiratory pressure, depending on whether flow is fully decelerated, if you use a decelerating flow pattern. But patients that have active respiratory effort, especially if that effort is high and they are using that effort or that reduction in pleural pressure to generate tidal volume, right, to inflate the alveoli, then their plateau pressure is higher than that peak inspiratory pressure, right? And so here's an example of a patient on pressure support. You see the esophageal pressure tracing that's here. The patient has about a 15 centimeter of water deflection in esophageal pressure with each breath, right? And if we, again, just look at what we see on the ventilator graphic, right, and you look at the airway pressure, this is only, a pressure support level of 7 or 8. When you do the hold, inspiratory hold, and the patient becomes passive at the end of inspiration, now you see that, in fact, this plateau pressure climbs above that peak inspiratory pressure, and there you can estimate the driving pressure, right, the driving pressure even under patients that are breathing spontaneously. This is really what the lung is seeing, and this is probably what we need to pay attention to as we're thinking about the potential risks of lung injury on these patients. And this is a nice recent adult study that looked at this concept of the driving pressure during assisted ventilation and the relationship that might have with outcome. And these are a relatively small study, but still it highlights this difference between driving pressure, as you see here, over time, and mortality, with the non-survivors here being in purple and the survivors here being in green, and you see this clear separation that happens over time. Now, sometimes you can't actually calculate the driving pressure because the patient does not become passive at the end of inspiration. And so here you might look at instead this dynamic transpulmonary pressure. The dynamic transpulmonary pressure is the peak inspiratory pressure minus the PEEP plus either the delta PES, or you can estimate this from the occlusion pressure, which we'll talk a little bit about later, 2/3 times the occlusion pressure. And here you see even clearer difference between the dynamic transpulmonary pressure in patients that survived versus patients that died. Okay, so the last concept about ventilator-induced lung injury and patient self-inflicted lung injury is the appropriate choice of PEEP, right? And this is the age-old debate, I think, in critical care of what is the right way to manage PEEP, and we don't have an answer yet, right? But what we do know, certainly, is that not every patient benefits the same way from PEEP. There's a heterogeneous response that patients have to PEEP titration and management, and so certainly individualized approaches are likely the best thing that we should be doing. What are the factors that may predict that individualized response to PEEP? Perhaps it's oxygenation, as we've seen. Perhaps it's the degree of inflammation, right, as an example. Now, historically, we've thought about sort of PEEP in relation to the PEEP FiO2 table. And I'm bringing that up because, in fact, that's what we used in our trial, just so I can set the stage for it. As we think about the PEEP FiO2 table, there's the low PEEP FiO2 table, which was the sort of standard table that was used, and compared to the high PEEP FiO2 table in the adult trials of high versus low PEEP. And you'll notice big differences, right, in PEEP levels here between the low PEEP and high PEEP table. At 60% FiO2, that's a PEEP of 10 on the low PEEP table. It's a PEEP of 20 on the high PEEP table, which I think gives most pediatricians when they think about that PEEP of 20. Maybe you shouldn't have a heart attack, but regardless. But what do we do in actual practice, right? In actual practice is what's in gray, and from observational data, at least this is now about 8 or 10 years old, we didn't escalate the PEEP as the patient became more and more hypoxemic. It seems to be we pick a PEEP around 10, maybe at the most 12, and don't seem to escalate it nearly as much. And that was certainly associated with harm, that not managing PEEP, at least in line with the low PEEP FiO2 table, was associated with higher mortality. Now, there is a clear relationship, right, between stress and strain and recruitment of the lung, right? And so if we think about this relationship, which is the elastance of the lung given by the transpulmonary pressure on this axis and lung strain on this axis, right? If I have a fully de-recruited lung, right, I might be on a very dangerous point of this stress-strain relationship. If I am able to effectively recruit the lung, I shift this curve, right? And by shifting this curve, I move to a safer place, I think, on that stress-strain relationship. So this is what underscores the idea of trying to recruit the lung and use PEEP to keep the lung open to improve, right, that stress-strain relationship and operate at a better point. And of course, this was the strategy behind trials such as the ART trial, where you would do a recruitment maneuver-based approach followed by decremental PEEP titration, right? This was a relatively aggressive recruitment maneuver in these adult patients, starting with a PEEP of 25 and a delta pressure of 15, going up to a inspiratory pressure of 50, followed by decremental PEEP titration, re-recruit the lung, and then manage the PEEP in that point of optimal compliance based upon the decremental PEEP titration. And what happens? Patients died, right? Higher mortality in the ART trial in the intervention group compared to just the empiric low PEEP FiO2 table-based approach. What happened? Well, the challenge with this, of course, is that many patients really did not benefit from this strategy and were directly harmed from this approach, from hemodynamic compromise or from the development of air leak. And so this is what underscores the idea that before we use very aggressive recruitment maneuvers, we probably need to have an idea of what patients, in fact, may benefit from it, what patients truly have recruitable disease for which you approach. Okay, so now let's move to the last area, which is diaphragm dysfunction. And when I think about ventilator-induced diaphragm dysfunction, right, conceptually, how does this manifest? This manifests in that patient that's difficult to wean, the patients that's difficult to get off the ventilator. And if we think about why patients may either fail extubation or have a very prolonged weaning phase, right, it's if there is this imbalance between respiratory load and respiratory capacity. When I think about respiratory load, these are the issues that get the patient on the ventilator in the first place, right? Resistance, compliance problems, right? When I think about respiratory capacity, this is what's the force generating capacity that the patient has. So if they have pre-existing neuromuscular disease, I know that that's already impaired as an example, or if they acquire it from being on the ventilator for a long period of time, right? And when there is this imbalance, that's when these patients struggle the most. So how can we measure diaphragm dysfunction, right? I would say there's two sort of high-level techniques that we can think about. One is an indirect measure with ultrasound, right? So we can look at the change in the size of the diaphragm over time as a measure of a change to the architecture. Perhaps the diaphragm thickening fraction might give us some hint at this as well. Or we can do direct measures, which is how much force can the patient actually generate, right? And that would be with an airway occlusion maneuver as an example to see the PI max, or the maximum force they can generate. Now, this is not only diaphragm. They will recruit additional muscles at this point, but it gives you a sense of whether they've developed weakness. Certainly, the adult data supports the use of ultrasound. It supports this idea that there is these phenotypes of patients that develop diaphragm dysfunction, with the largest phenotype being those that have atrophy of the diaphragm, One of the major risk factors for atrophy is subphysiologic contraction of the diaphragm. So patients that have diaphragm thickening fractions that are low for the course of ventilation are the ones that are at the highest risk of developing atrophy of the diaphragm. There's also a small subgroup that develops hypertrophy of the diaphragm from excessive diaphragm thickening or excessive contraction over time. And this, even though this is hypertrophy, it results in a mechanical disadvantage of the patient. It actually is not as well functioning, even though it has hypertrophied. Now, in pediatrics, there are limited data evaluating the trajectory of change in diaphragm thickness over time. There's limited data validating the thickening fraction as a reliable measure, especially as we think about the age variation, right, that we have in children from some of the neonates to the oldest of children. This is work that we've been doing now for several years, more to come on this, but the validity of diaphragm ultrasound, personally, I'm quite worried about it in terms of its use in pediatric patients. What are some alternatives? Well, there are the direct measures, right, of respiratory muscle strength, such as the PI max maneuver, right? And I think that there's a hesitancy to measure PI max in some pediatric patients because people believe that, they're uncooperative. So how are they going to do a maximum effort? Well, if you adapt the method that you do to do this, right, you actually can do this very reproducibly on all pediatric patients, even neonates, with continuous breath occlusion. So disconnect, connect a manometer, keep the airway occluded continuously for 3 to 5 breath attempts. And you see this pattern where the effort increases and then plateaus, typically by the 3rd to the 5th breath. And if you measure that maximum deflection, right, this is the PI max. And we've shown, and others have shown and consistently, right, that there is a clear relationship between risk of reintubation and PI max. The thresholds might be different in different studies, but there's this dose-response relationship. And so if we pick 30 as an example, what we saw in one of our studies here is that patients with PI max less than 30, right, had about a 3-fold higher risk of reintubation compared to those with a PI max greater than 30. And where this manifests the most is when you have this combination of this impairment in load and capacity, right? So one of the most common things that we encounter in terms of failed extubations in pediatrics is post-extubation upper airway obstruction, right? And so what we saw here is that when patients get post-extubation upper airway obstruction, if they have maintained respiratory muscle strength, the risk of reintubation is only marginally higher than what we would see in the overall population. But if they have that double combination of post-extubation upper airway obstruction with a low PI max, 50% reintubation rate. So it's that combination of things when it's put together. So this is how diaphragm dysfunction might really exacerbate problems with weaning for patients that either have persistent impairments in respiratory compliance or resistance, or they develop new impairment like post-extubation upper airway obstruction. So if we think about how we might target prevention of diaphragm dysfunction, right? Well, what are the major risk factors? Lots of things that we can't have an immediate control over. Disease state of the patient, degree of inflammation, neuromuscular blockade, steroids, maybe we can control that a little bit, degree of protein catabolism. But perhaps the thing we have the most control over is how we manage the ventilator, right? And if we provide over-assistance to the patient, right, then they have no use of their diaphragm, right? They are not using it, and this is where the risk of atrophy may come in. So if we think about the bundled components that we would put together to try to target and create a lung and diaphragm protective strategy, these are the concepts. We want to prevent lung strain, so we want to do tidal volume relative to the size of the lung. We want to prevent lung stress, so we want to limit inspiratory pressure, right? Ideally, transpulmonary pressure is the direct measure, but certainly otherwise driving pressure or plateau pressure. Prevent atelectasis trauma by having a method to provide adequate PEEP, right? And then trying to prevent diaphragm dysfunction by promoting a physiological amount of respiratory effort with each breath if we can. So trying to prevent over-assistance myotrauma. Now, what are the targets for respiratory effort and what do we know what's physiological? There's lots of potential theories that might be out there. The most direct measure is to measure the pleural pressure. So to use esophageal manometry and measure directly either the peak to trough change or the delta PES and target that value as a surrogate for PMUSC, or some combination of that with the respiratory rate, such as the pressure time product, integration of that area, or what we have tended to use as a simplistic version, the pressure rate product, which is the peak to trough change in the esophageal pressure times the respiratory rate. There's some other options like EDI that certainly could be used. Increasingly, we've now validated the use of airway occlusion maneuvers in pediatrics, thanks to work by Yuki, for example, in the front row here, that shows that we can use these in pediatric patients too, and there's a clear relationship between delta PES and the airway occlusion values, or maybe a diaphragm ultrasound, although again, I'll say that the pediatric data is a little bit questionable there. There has been some initial proof of concept work that was done, certainly in adult patients, where you can use adjustments in the level of pressure support, to target maintenance of respiratory effort in the target range. And this is Leo Henks's work, right, where this was a protocol using transdiaphragmatic pressure, so two balloons, a balloon in the stomach and a balloon in the esophagus, trying to target that range of 3 to 12 centimeters of water. And you could see that with this pressure support titration protocol, right, they were able to keep the intervention patients in that range 75% of the time or so. So for the last 8 years or so, we've been working on RedVent. RedVent is the real-time effort-driven ventilator management. It is this bundled intervention to try to deliver lung and diaphragm protective ventilation that is executed at the bedside with the aid of a computer decision support tool, which is a web-based interface, right? It's available on any web browser, that gives recommendations to the respiratory therapist typically at the bedside to make a change to oxygenation and ventilation with each routine ventilator check every 4 hours. And the rule set has rules for changing pressure, changing rate, PEEP, FiO2 management, and it's also trying to target maintenance of respiratory effort in that physiologic range with a direct measure from esophageal manometry. So these patients had an esophageal catheter at the bedside, and the respiratory therapist would put in information from the esophageal manometer into the CDS tool to generate that recommendation, okay? Now, we recently completed a phase 2 randomized trial that we just published in May, and I'm going to share the results with you. This was a phase 2 single center RCT in pediatric ARDS patients. We randomized patients in both the acute phase and the weaning phase. I'll talk about that in a second. And the patients that were in the intervention arm received this computer decision support tool in both phases, okay? And our hypothesis is that when we implement this strategy that tries to minimize controlled ventilation and promote more spontaneous breathing by systematic weaning of ventilator settings, right, we would prevent diaphragm dysfunction and facilitate ventilator weaning. What's the intervention? So the intervention in the acute phase, these patients were all managed in an SIMV pressure control, pressure support mode. PEEP management was based on the low PEEP FiO2 table, okay? And then we had peak inspiratory pressure based limits that had progressive permissive hypercapnia based upon the inspiratory pressure. I'll show you that in a second. The diaphragm protective protocol was esophageal manometry, targeting a pressure rate product between 200 and 400. The weaning phase was a pressure support mode of ventilation only, so no rate. PEEP management was for the clinical team between 5 and 10 centimeters of water, and then the level of pressure support was adjusted to achieve that PRP in that target range. This is a setup, an example of the system in play. This is a patient that's undergoing a spontaneous breathing trial, so we have these RIP bands in, but you see the esophageal catheter that's connected to a hardware device. We had a laptop at the bedside, which is continuously displaying the PRP, and then an iPad was also there to generate the recommendations. Patients were randomized, that were eligible were randomized at the acute phase, 50-50 to RedVent or usual care. Then every day, patients in both groups went through this standardized weaning criteria screen that you see over here. If they met this criteria, then they had first an oxygenation test to make sure they could tolerate the lower PEEP. If they could, then they underwent a spontaneous breathing trial on CPAP alone. If they passed, we gave a recommendation to extubate. If they failed, then they went on to the weaning phase where they were randomized, again, they could switch groups, right, into the RedVent group, which was, again, pressure support, targeting keeping the PRP in that target range, or clinician weaning per choice. But there was a daily standardized spontaneous breathing trial that was done in all groups until they passed. What's the rule set? So here's how the rules worked. In the acute phase and the pressure control mode, you'll see that there's a table-based system that, based upon the pH, either directly measured or estimated from capnography using equations that sort of account for changing dead space, and peak inspiratory pressure, it would give a recommendation. So for example, if the peak inspiratory pressure was 30 and the pH was 7.31, it would recommend decreasing the delta P by 2 centimeters of water, right? Where the green cells come in is where the effort of breathing modifications come into place. So if the patient has low effort, this would enact the recommendation. If their effort was actually in the appropriate range, it would maintain ventilation. If their effort was high, it could in fact increase ventilation to a certain extent till we reached our upper limit of the protocol, and then it would give a recommendation that the upper limit has been met. Consider adjustments to sedation or something else at that point. PEEP management was based on the low PEEP FiO2 table. You see these green cells. So if a patient, for example, was on a FiO2 of 0.7 and a PEEP of 8, and they were in the low oxygenation component, then it would recommend increasing the PEEP by 2 as an example. So it's trying to drive them to those green target cells. I talked already about the weaning phase. In both groups, we placed an esophageal catheter. In the intervention group, it was for management. In both groups, it was also used for spontaneous breathing trials. So as part of the spontaneous breathing trial, patients had to meet certain criteria for passage or failure, and this was identical between groups. So this is to ensure that there was reproducibility in the outcome measure that was done the exact same way between groups. And in fact, the most common reason for failure was based upon high effort of breathing with a high pressure rate product. So this is why I think it's even more important to use this as a criteria for SPT passage. So our primary comparison was red vent acute versus usual care group. The primary outcome was duration of weaning. This is a phase 2 trial. So we cannot do ventilator-free days in a phase 2 trial, right? We have to start first with the most sort of appropriate physiologic outcome that also has clinical relevance. And so this was duration of weaning, time from the first SPT until passage of the SPT. And then the secondary outcomes are all the ones that I think we also would all care about, of course: mortality, length of ventilation, ventilator-free days, SPT outcomes. So we had about 600 patients that met inclusion criteria, of which 340 had no exclusion criteria, and we enrolled 248, so about a 73% consent rate. If we look at the patients that were enrolled in the study, 125 in the red vent group and 122 in usual care, they were quite similar with baseline characteristics. I'll just of note, about 30% of our patients were immune compromised. About 40% of them had either neurologic or neuromuscular disease. This is not uncommon in tertiary care PICUs, right, where we have a lot of patients with chronic comorbidities. The only real difference between the groups at randomization, and this was just unlucky with randomization, is that the red vent group had slightly more patients with an OI greater than 16 and also had higher use of nitric oxide on the first day. So all models were adjusted for oxygenation index given a slight imbalance due to randomization. This is the fidelity of the intervention. So from this, what the take-home point is that people followed the recommendations. So this is the number of or percentage of recommendations which were implemented for oxygenation, ventilation, and weaning recommendations. And as you can see, they're all very high, well above 90%. So people followed the protocol. What that resulted in is the separation of the key variables that I would say drives differences. And what we found is in the red vent group, these patients were managed with the lower peak inspiratory pressure, about 3 centimeters lower peak inspiratory pressure compared to usual care, 2 centimeters of lower on average delta pressure, peak inspiratory pressure minus PEEP. That resulted also in a lower plateau pressure in the red vent patients. Similar driving pressure and similar tidal volume, okay, but higher respiratory effort in the red vent group, so more delta PES. So how do you conceptualize this, right? So the idea of what this is doing is it's saying the driving pressure is really driven by what the patient wants in a pressure control mode and the tidal volume. Those are similar between the groups. But in the red vent group, more of that pressure is being generated by the patient. In the usual care group, more of that pressure is being generated by the ventilator, if that makes sense. Okay? PEEP FiO2 management, what we see here is a red vent group is in red. It follows the PEEP FiO2 table generally, right? The usual care group is in gray, and interestingly, The PEEP level used in the usual care group actually was higher than the red vent group at low FiO2. So this implies that people are not turning down PEEP in the usual care group very often, at least not even when oxygenation is low. At the higher end, though, the red vent group also had higher PEEP that was used compared to what we see in usual care. We look at the primary outcome, which is length of weaning. We saw red vent resulted in a faster length of weaning. And the way you can think about that first is look at that first SBT, which is here on the left. So 55% of red vent patients passed their first SBT or were weaned on the first day that they were eligible for weaning, compared to 39% in usual care, resulting in a significant improvement in length of weaning. Secondary outcomes, time to SBT passage, about a 20% shorter time to SBT passage in the red vent group compared to usual care, and about a 20% change as well, or 20% reduction in length of ventilation in the red vent group compared to usual care. This is a summary of all of the secondary outcomes. So here in this graph, things to the right favor red vent, things to the left would favor usual care. So you see length of weaning, first SBT success seems to favor red vent, actually a higher PI max. So these patients had more maintained respiratory muscle strength on the day of their first SBT in the red vent group. No real difference in PI max on the day of extubation, ventilator-free days. Perhaps a signal for improvement in functional status at the time of ICU discharge, although that was not true at the time of hospital discharge. This shows on the left those that would favor red vent, and on the right those that would favor usual care. Faster time to first SBT, shorter length of ventilation, similar use of non-invasive ventilation after extubation, similar mortality, perhaps some signals for ICU and hospital length of stay, although not significant, similar cerebral and overall performance groups. And interestingly, at hospital discharge, there seemed to be a signal that the usual care group had a less decline in overall pediatric cerebral performance category, but this was only like 4 or 5 patients, so we have to interpret this with a lot of caution. That's why the confidence intervals are so wide. So, to conclude, lung and diaphragm protection requires a balance between controlled ventilation and spontaneous breathing, and ideally, we should be trying to promote spontaneous breathing in a physiologic range as long as we can simultaneously guarantee, right, that we're limiting stress, strain, and what I did not talk about is asynchrony, but I'm going to talk about that a lot tomorrow over at the Congress if you're able to join there. This involves assessing driving pressure, assessing respiratory effort, making sure we're choosing tidal volume based upon the size of the lung. Now, we chose these thresholds based upon previous physiologic data. It's unclear if these are all the most appropriate thresholds. We don't know the answer to that truly, but we have to start somewhere. And so this is where we start. And certainly if we show that these are helpful, then we can move the thresholds a little bit more. And I'll stop there. Thank you.
Thank you very much for your excellent lectures. Is there questions or comments from the floor?
Thank you very much. Yeah, excellent lecture. My name is Kazutoshi Cho from Hokkaido Prefecture. I'm a neonatologist.
Okay.
I understood that low tidal volume and good synchronicity protects the patient's lungs. And to decrease the tidal volume, we have to choose the higher respiratory rate or permission for hypercapnia. Mm-hmm. So which should do you choose?
Yeah, that's a good question. And I think it depends certainly on where the patient is. You're a neonatologist, right? That's what you said. So it depends on if you're controlling fully and the patient's paralyzed, right? Versus if you're allowing them to breathe spontaneously, right? And where that balance point lies. So if we're trying to allow them to breathe spontaneously, which of course would be the goal as long as it can be done in a safe range, then certainly a reduction in the tidal volume can be compensated for if the patient wishes, right, for the higher respiratory rate. The challenge that I think is important, and in neonatology it becomes even more complicated because you have uncuffed endotracheal tubes, is it becomes difficult to really actually know what the driving pressure is for that patient, to figure out what the most appropriate tidal volume might be, right? So synchrony is what also comes into play in that scenario, right? And in fact, actually, I'm going to use this as an opportunity to show this. This was a question that I had for you guys, and maybe this illustrates the point. So tidal volume selection, synchrony has to come into play in making that choice, in addition to knowing what the driving pressure is for that patient, right? So if you have this scenario, okay, 18-year-old, we could say a younger patient, right, for our own purposes, pneumonia and ARDS, managed in an AC PRVC mode of ventilation with the tidal volume of 6 per kilo, PEEP is 10, FiO2 is 0.5, plateau pressure is 22, rate is 22, triggering each breath, there's the blood gas, okay? There's your flow and airway pressure tracing. So in this scenario, I would say this looks okay, right? This tidal volume is probably appropriate for this patient. There's no significant flow dyssynchrony. The plateau pressure is in the safe range, right? pH is in the safe range in this point, right? Driving pressure is good. Okay, we'll leave it alone. What if you see this? It's the exact same scenario. Everything is identical. What should we do? What's happening here? So the patient's frequently having this, right? So the patient is having a breath stack, right? Both breaths here are patient triggered. And when you look at the flow tracing, there's a significant flow dyssynchrony. So what this is highlighting is that tidal volume is not enough for that patient, right? If we're allowing them to breathe spontaneously, right, they want more flow. And if we don't give them more help or more assistance, they're going to have a lot of breath stacking that's occurring. And that breath stacking, if that happens frequently over time, that's probably more risk for ventilator-induced lung injury, right? And so if in this patient, even if because the driving pressure is in a safe range, I would increase the tidal volume on this patient, right, in the PRVC mode to give them more flow, as long as I can keep that driving pressure in the safe range, right? Now, to answer the rate question, right, I don't know what the upper limit of rate is that's allowed or acceptable, right? If the patient is breathing spontaneously, I can keep the tidal volume and the plateau pressure in a safe range, and they're tolerating that fast rate and not having a significant amount of breath stacking, et cetera, I would allow that rate to be what it is. Mune might be able to tell us this answer as he investigates mechanical power a little bit more, right? To try to understand what the rate contribution is, in the mechanical power equation. But at least to my practice now, I pay the most attention to the to the driving pressure and the tidal volume, and then I allow the rate to be what the rate is going to be if I'm trying to preserve spontaneous breathing and can keep effort in the normal range. If I'm controlling ventilation, right? So now if I've decided I can't allow this patient to breathe spontaneously, right? Then once I get my driving pressure and my tidal volume in what I think is an acceptable range, then I use a rate to try to prevent auto PEEP. And that's what I'm looking at to determine the rate and allow how much permissive hypercapnia I allow.
Thank you very much.
Yeah.
I'm a neonatologist, so always use IMV or single SIMV or respiratory pressure support to managing the tiny babies.
Yeah.
Yeah.
Other questions? Can I ask you one question?
Yeah.
You measure the inspiratory effort. I mean, the inspiratory ability to do the PI max.
Yep.
In adults, some physicians use the peak expiratory flow to evaluate the cough ability. Do you check the cough ability to the patients? And if you have the technique, please show us the sample.
Yeah. I do it qualitatively, not quantitatively. Yeah. So it is definitely assessment of cough is definitely something I do as part of my extubation readiness assessment, right? And a patient that cannot generate a subjectively strong cough is somebody that I, of course, am more worried about for failed extubation or prolonged weaning. I may extubate to non-invasive ventilation. But I don't have a good way to quantify it. It is all subjective of put the suction catheter in and say how big of a, how much effort does it seem like this patient has? Yeah.
Thank you, Benjamin. I don't have the technique, so I ask you. Thank you very much.